Hello, and welcome to the Innovation Forum AI podcast, a space where we explore how artificial intelligence is transforming public health. Welcome, everybody. My name is Oliver Morgan, and our guest today is Laura Espinosa, an epidemic intelligence expert at the European Centre for Disease Prevention and Control, ECDC, where she works on applying AI, automation, and data-driven methods to support public health surveillance and decision-making. Welcome, Laura. It's great to have you on the podcast.
Thank you. It's really a pleasure to be here with you today.
Well, Laura, I thought we'd jump straight in and really think about AI in the context of public health and public health surveillance. And in conversations that you and I have had in the past, I know that you often like to emphasize the importance of public health when thinking about AI solutions rather than starting at the point of AI. Maybe you could explain a little bit of that way of thinking.
Yes, sure. So if we think about implementing AI in public health and we do it from the problem-driven, so starting from what is the problem in order to decide when AI would be an added value and which AI, what we get and how it changes the design of the project is that, first of all, these are prioritized by the public health impact and not by the popularity of a specific AI solutions. Also, by doing it this way, we get the design of the solution following what we call the agile framework. And what is based is that it started from the end user perspective and the needs, and it also uses a lightweight method. So not a really cumbersome method that is difficult sometimes to understand for public health experts. And in order to really define the features, what we need for those solutions. It will also allow to understand those constraints. So before starting with the solution, we know from the beginning what are the capacities, what are the constraints in our context, which may vary, and also for the use case, rather than finding those later in the process. We need to understand that starting this type of projects, it takes a lot of efforts, a lot of money and time. So being able to get all this information from the beginning really reduces the problems throughout this process and being wasting all that information, which of course, that doesn't mean that it will guarantee 100% that everything that is done problem-driven will end up with an applied solution in our processes, but at least it increases the possibilities of those solutions being implemented in our workflow.
We've experienced in our work is that having an agile approach at the beginning is really important to really test out the idea before you invest too much time and effort into any new venture or project. But maybe you can give us a sense of what are the kind of projects or activities that have survived the transition from the concept into an actual day-to-day product for public health.
Yes, indeed. So there, I would say, there are several solutions that will survive in a higher rate, so less mortality rate in this case, from the concept to our routine use. And those will be those that are solving a concrete and well-defined problem. So we need to define the problem that reduce the workload and it does not increase risk. We need to ensure that by reducing this workload, we are not creating a new problem. Also, it has to tolerate imperfect data. Maybe we'll talk later on this, but working on epidemic intelligence, public health intelligence, we are dealing with unstructured data, unofficial data. So if those solutions are only available for data that is perfect, it will never go into routine use. So it has to keep that in mind. It also needs to support the work of the analyst. So it's not about replacing them, but really supporting that work, and also goes back to this avoiding having more risk when having this type of solution. Also, others that will survive this transition will be those that are integrated in our systems and workflows. We cannot develop a really complex AI solution in an environment where there are some basic structures, IT infrastructures that are not there, because it will not be able to be used at some point. It would not continue the development or even the deployment. And of course, that a point that is really relevant is explainability. We need to ensure that we have some kind of explainability and robustness when implemented in public health, also depending on our use case and what could be the consequences. So those are also other aspects to keep in mind to ensure this transition to routine use.
Yeah, I mean, these issues, I think, are quite well understood across the range of different AI-related projects. But I think in public health, we often have a smaller threshold for failure or for not having success, because we're often investing public money in a lot of these solutions. So it's definitely quite challenging. You mentioned a moment ago your work on epidemic intelligence, and that's actually an area that we've collaborated on in the past. I mean, that's epidemic intelligence often uses open source information, which itself can be quite difficult to work with. What's been your experience applying AI to such challenging data?
Yes, I think I would like to also start with some key concept of what is epidemic intelligence, so at least all listeners of the podcast understands where we're starting from and where we are reaching. So first of all, epidemic intelligence has as a main objective trying to detect threats at an early stage. That means that we are dealing with noisy data, but we want some kind of noise. If we don't get that noise, we may wait too long and it may be too late in order to apply any response or any action. So we need to accept, and we kind of want that type of noise at some level. It has different steps, and we've built all our solutions at ECDC trying to improve each of these steps in a modular way and not trying to improve everything as a whole. As I mentioned before, we need to have a clear objective. So it goes from this vast amount of information. We're talking about structured data, unstructured data, official, unofficial, tables, images, text, almost everything. And from that, we need to filter what is relevant for the institution, which is usually based on mandate, on what is the region that is covering, validate the information. It's important, especially when talking about mis and disinformation. We need to ensure that what we are communicating is valid and is accurate. And we need to then assess to decide whether further actions should be needed. In all this context, one option that could improve the use of this data, also considering changes in data accessibility or availability, is automation and machine learning. One example is an R package that we developed in 2020. It was when it was first published. It was called EpiTweetR. And it followed, and going back to the problem we had. We had social media. We wanted to possibly detect threats from there. So we had to do it manually. And that entitled to have a predefined list of users. So we had to look for which users to follow. And it was not comprehensive. And of course, the algorithms in these social media platforms, I think anyone using it will see, the more you look into something, the more you get on that. And then you can create this bubble of information, and you are not able to see what is outside that. So with this package, what we did was to turn from this manual monitoring into automated trend analysis. It's open source. It was basically the code based in R, and then each user would need to input their credentials. And also in terms of data privacy, explainability, all the data will be stored locally, and it's using open source free of charge. So it had different components of AI. So the way it started is that users will provide keywords in the languages that they were following. The tool allows for over 150 languages. So I will not say all, but I would say quite some. It does not do translation, but it supports the interpretation. So from the human text into the computer text to get this post. And then it will aggregate them per topic, time, and location. And the objective was to see if there was any potential signal. And by signal, I mean an unexpected increase of posts for a specific topic, so conversations, in a location and time. Once we had that signal detected, then we would need to see whether it was a true signal or not, so categorize the signals. So that was a second component that the tool had that allowed to, by providing the list of categories, so it can be discard, relevant, monitored, it can be really adapted to the user's need. Then the system will try to categorize these signals. And it also allows for supervised learning, which means that then users could train the model by annotating some of those signals and the model will learn from that. And the last component was about geolocation, so getting the location from the text of the post, not from the users, to understand where those events were being happening. In this case, as mentioned, it covers automation, machine learning. We also did evaluation. That's also another aspect that we want to try to implement in all the solutions to understand, after our initial thoughts and theoretical added value, what is the real added value. And when comparing this automated monitoring, in this case it was Twitter at the time, with the manual monitoring, we saw that EpiTwitter had a higher sensitivity and higher timeliness, lower specificity as expected because there was much noise, but overall it showed it added value into the epidemic intelligence processes. We also built this tool in phases, so some of those models and functionalities were added throughout the years until it was more or less covered for what needed. What happened in 2023 is that the data accessibility to Twitter, that then it was renamed to X, changed, which means that we were not able anymore to collect data. And of course, the Twitter was not being able to be used. And it was a pity because the rest of the pipeline, collecting those posts, aggregating them, finding the signals, were agnostic to any social media platform. But since it was not thought that that can happen, again, trying to think on all the different things and having to adapt as we go, we say, okay, let's step backwards for a second. And we did in 2024 a literature review on which of the 36 pre-selected social media platforms that we included could have a context of relevance for public health and more specifically for ECDC mandate, and that had mechanism to get that data. At the end, we had 6 platforms. And then last year in 2025, we modified EpiTwitter. Now it's called EpiSomR from social media instead of Twitter. And it contains data collection from Blue Sky. Other social media are planned to be included in the future, and it's already built in a modular way to ensure that what happened in the past with one social media platform may happen to others. So we are already ready to adapt the tool for future constraints or future blockages in that accessibility.
Thanks, Laura. I mean, EpiTwitter was really a great tool when it first came out. I remember when it first came out and during the pandemic, and we used it a lot as well. And we'll put links in the show notes to a lot of the papers that you're mentioning. But I think it really underscores the fact that this is a very dynamic field, and data sources change, and the approaches to interacting with data sources also changes over time. But fundamentally, I guess we're using AI to help prioritize all of these different signals coming from multiple different sources of data, rather than exactly using the AI to select the signals themselves. Is that how you're still using it?
Yes, and again, trying to go back to the problem, setting the scene on this for another problem or challenge that we prioritize as needed was how to do this prioritization in the screenings that we do in the morning. So the way we work at ECDC, every week, every day, there's one 24/7 duty officer supported by a threat detection officer during working hours. And they have 3 main screenings throughout the day. There are some in between. We mainly use EIOS, Epidemic Intelligence from Open Sources, which is a really nice platform that collects data from a lot of sources in one go. So instead of going to different platforms, you have all your information there based on a dashboard. And a dashboard would be created based on location of those news items or other articles in EIOS and the topics. So our main problem in this case was that we have a daily meeting with experts at ECDC from different public health functions, from different disease programs at 11:30. And when starting the screen at 8 a.m., it has happened that maybe we find something that is really relevant just before this meeting, which of course give us a short timing to take any actions, validate information, because we are doing the screening backwards from the last time that was done the day before at the evening night. So we were thinking, what if we had a tool that will help us to prioritize this, We are not talking about substituting anomalies or reducing the noise. We are just talking about reordering this noise. So at least we can start with those that may seem more relevant, that may require more actions. So then once those are covered, we can go to the ones that are less relevant. So what we did in this case was to develop a machine learning approach, what is called unsupervised, because we want to see how these different patterns, underlying patterns that we cannot see. So if we have thousands of articles in one go, it would be difficult for the human eye to try to group them and trying to see where those possible anomalies or unexpected signals may come. So we had these two levels, and those two levels were created because we wanted something fast, but we also wanted something a bit more complex, which of course requires more time. So our primary clusters were focused on categories, countries, and publication months. So it's a bit rough, but it could give us a quick idea of what was happening. And then we had a secondary cluster, which was focused on these primary clusters and also the article title and description in English when available. I mean, we're talking that it will take to run all of these for the past 6 months, like maybe 1 hour for the primary, an hour and a half for the secondary. So it's not a lot of time, but maybe those 30 minutes could help us to get some information before. And the anomalies were just those items from EIOS, articles that were not included in the clusters. In this case, we used open source solutions because we thought that maybe something that other institutions from the EIOS community could benefit from. So we thought in case, similar as how we develop EpiTwitter, they can access and they are not depending on which commercial solutions ECDC had at that point. So the way it works, more or less the process, we have the text, we had to translate it, as I say, in a way that computers will understand, which is extracting those embeddings, reduce the dimensionality because we had a lot of variables. So we had to focus on those that would be needed also to be faster, but still with relevant information. We'll do the clustering, and then we will also run a final step to get a topic of those clusters, because otherwise we would see clusters with some numbers that means nothing to human, more to the computer. So again, thinking on the end user. We also did evaluation for this. There's also some links that probably can be added for the podcast for the users to see. And during a week, we found around 7,700 deduplicated items from EIOS. And from those, we got around 1,000 anomalies from all the primary and secondary. And although only 40% of the secondary anomalies were relevant, from those 20% were not detected manually. So again, why not substituting the analysts? Because we are sure we would miss the information, but in combination with the analyst work, it would be a much efficient and higher quality information that we are collecting here.
Yeah, I mean, I think that's a really great example of where adding AI to an existing workflow can actually not only make it more efficient, but more effective as well. And as you said, the combined process was able to pick up and kind of look at more signals in a shorter period of time, not just reduce the amount of time taken to do the previous workload. Just out of curiosity, I mean, it sounds like you were taking an open source AI model and either kind of fine tuning it for your purpose. I mean, could you just quickly walk us through that process and how difficult is that for a public health agency like ECDC?
Yeah, so in this case, what we did was actually use pre-built machine learning models. The fine-tuning was the assessment that the analyst would do at the end. We decided to go this way because we knew that if we were going to train this model, it will take a lot of time. And for a situation like this, that is a support or a complement on what we are doing, it would be probably not the best way to focus their resources. So in this case, as I say, it was open source. We did not need additional fine tuning because we were doing a task or an objective that was in complement with what the analysts would do. So that's why we decided to go with what's already available. Again, open source and being unsupervised, we did not have that additional layer of having additional information. It can be added. We did it with EpiTwitter. We had only the categories of those signals, and then we decided to add that additional level. So of course, that's something that could be added in this way. So we started with small, and then if required and what was needed, that's something that can be added at later stage. So.
Okay, so that's encouraging. So actually now I guess some of the open models are kind of good enough to be implemented with without too much adaptation. So Laura, a big decision point is really whether to go with an open source model or a commercially available model. They both have pros and cons, of course, but how do you go about making that assessment, and any tips for others who are faced with the same challenge?
Yes, it's a common challenge. So I will start from that. If you don't know, if someone doesn't know what to take, you're not alone. We all been there. There are different, I would say, considerations to keep in mind when selecting one or another. And so, for example, transparency, how much we need to know what is behind the model. The cost, the commercial solutions may have some license costs, but also the ones that are locally deployed or open source is not a cost in licensing, but there's some infrastructure and stuff that will be needed. So which of the two is needed for each case? The performance. There are some commercial solutions that are already built to have scalable performance, whereas maybe others from open source, it requires a bit more input from the users, from the experts in the different institution. Technical expertise. If we are going from open source, we will need our in-house expertise. If we go to commercial, we depend on the vendor, which also links to the vendor or the tools lock-in, meaning if you buy something from a specific vendor, if you want to change to another vendor, it would be more difficult. So you may end up having to buy everything from that one. So it's also something whether we want to invest, or we can invest at the beginning of the process for later on, or we want to do it later on. Also integration, how it integrates in our systems, how easy is to be customized. When developing EpiTwitter, we initially looked for the different solutions that were available for social listening, and we realized that all of them were not able to cover our needs for threat detection. So we thought if we need to start from a solution that half of the features are not available, maybe it's better that we build our own solution so we can decide what we want to include or not. And then there's the part of the data privacy and responsible AI, and also the users that are intended to access this solution. So depending on the different regulations, maybe some of those commercial solutions are more tricky to get a fully understanding, because at the end, it's the institution that will be accountable for that, on how data is being used, how data is being stored, and so on. So if data is really sensitive and there's the possibility of having experts in-house and it's a long-term investment, having something that is locally developed will overcome that problem. And also for the users, I was briefly mentioning that for the solution we did with EIOS, we decided to go open source just in case, because we thought there's some likelihood that maybe other users from the EIOS community would be able to benefit from that. So in order not to restrict them to what we had at ECDC as commercial tools, to facilitate the implementation if needed. We had a similar solutions in terms of the technology being used. So in this case, it was to group items from our event management platform, EpiPulse, not to detect the anomaly, but to detect related events. In this case, it was really focused in our platform, really focused in our needs, that we decided to use other commercial solutions instead of open source to have a faster development, because we were not expecting to have other users developing similar things. Still, the information would be available. It will need more work to implement in another institution. But again, our focus was more to get something now for our needs rather than finding something that could be useful for other users as well.
So what type of tasks and what kind of data for epidemic intelligence are AI models really well suited for? Is it multimodal information such as text and images and audio and other types of information? Or is it more like just doing automation so that tasks are done a little bit more seamlessly?
Yeah, so in this case, maybe I can start also with the part of the automation. I think we get a lot of information nowadays on how large language models can be a benefit, and it can be, and I can refer to that later on. But also having less complex models allows, as you were mentioning, to have it applied in different contexts with less resources required. So when it comes to automation, the tasks that are really well suited are those that are recurrent and that they have, in a way, underlying patterns that are easy to automate. For those situations, there's no need of complex models, and also having something that there's explainable for being able to have a solution that we can explain why it gave what it gave. One thing to consider that when doing this automation at scale, we need to keep possible changes in mind. So things change, how the data, and I'll explain an example on this, may require fine-tunings of our automation code. And there can also, in those cases, small errors would also come at scale, so it will have bigger consequences. So we need to keep that in mind, that even with automation that are explainable, we still to keep the human in the loop to understand whether something has to be done. In our case, just to give an example, we are having active event-based surveillance on some long-term monitoring threats that we call. So events that we report on recurrent basis. It can be daily, weekly, or monthly worldwide. We also face a situation that during the COVID pandemic, we developed some code to make those automations, but then they were so specific to the data we were getting from COVID, to the outputs that we were doing from COVID, that it was really difficult to adapt it to other diseases. So those were our main problems. Okay, we need to have these reports automated in an easy way, also in a way that can be adapted to other diseases, and we don't need to start all over again when we have something developed. So what we did was to develop R scripts. So it was simple R scripts, so no complex AI models in this case, to automatize the validation of that data that we were collecting, summarization, and maps, and some other reports. So the design, it has a long list of scripts, which is a bit the part that the programmers, data scientists can deal with. But we have two main R scripts that look like a Word document. So you don't need to be a professional programmer in order to understand. You just need to see which lines you need to change, maybe the date, the indicators you want. And once you have that, by clicking on 2 or 3 buttons, you will get all this information out. We had to do some modifications. So once we had it, at some point, we changed the data collection tool, which changes the variables, the formatting. So that had to be modified. And then at some point, we faced the situation that we were reporting recurrently, but for unexpected reasons, in this case, it was cholera. For 2 or 3 months, we were not able to report. So the way it was built, it was giving errors. So because we did not anticipate that to happen, so we had to change it. Of course, changes in the text that we want to have to improve the messages. We did an evaluation of this initial development, also including the efforts that were needed to develop it, to adapt it, and what we were gaining from that. So in that case, there was a month to develop all this set of scripts with 2 biostatisticians and 1 epidemiologist, and 6 days of experts on epidemic intelligence that were working on this active event-based surveillance for cholera. And then annually, for this specific threat on monthly reports, we went from 18 days of work to prepare it to 7. Of course, one can think, well, it's just almost half. It can sound like, 7 days more, 7 days less. But we all know when working on public health intelligence, every single second counts. So we managed also to see what was that added value when having this. And again, having it ready for other diseases, instead of having, again, that month of development, it would be only maybe 1 week, which it's a huge difference that having to redo it for all the diseases like that.
Yeah, absolutely. That sounds like a really fascinating workflow. And actually something that jumped out at me when you were explaining that was the interaction between a range of different experts at ECDC to develop all of these different scripts, and then, to use the AI to work with the scripts to automate some of the workflows. I mean, how have some of the other experts in the ECDC adapted to implementing AI into the workflow? Is it met with enthusiasm, with skepticism? Do they feel threatened? Do they feel like they have a whole lot of work taken off their to-do list? What's been the reaction?
Yeah, I think that what we see here is what maybe we see everywhere. We would have people really enthusiastic to take on board AI for whatever, others that will take it a bit slower to see, okay, where it can really be implemented. Maybe others that I would say is not really to be afraid. I think is also how the information has come to public health. So later, in the latest years, there's been a huge focus on large language models, which again, it's really good for specific tasks. But if we think about it, it's one of the most complex methods that we have on artificial intelligence. And if we are approaching to someone that doesn't have knowledge on a topic and we go with the more complex part, I just think back to the university when, or even school, high school, when you see mathematics, statistics. If you start from the really complex method, you will be overwhelmed. And maybe you will say, this is not for me. I cannot deal with that unless you're really into the topic. So I think we need to ensure that there's awareness, that there's capacity building. We have tried to done it in our team, now section on epidemic intelligence, but also at ECDC to have a governance, to understand what is the strategy. So trying to build all these blocks to ensure that there's a common knowledge, or at least the basic knowledge. So we understand what are the benefits, what can be the areas where we need to be careful, how to mitigate those risks, where to implement ones or another. And some of the work we do, we also have outsourced specific contracts, because not so much on the lack of capacity or capability, more on the timing. So having that additional support, and as we see, it's a technology that moves really, really fast. So it's difficult to have an expert on public health that would be also with the top-notch knowledge on the different technologies. So by having interdisciplinary teams, that helps in building the different parts all together.
Yeah, I think the rapid development of AI and AI models is actually one of the features of AI, is that it moves so quickly. I mean, you actually did your PhD in applying large language models to understanding public health behaviors and public health data. How have you seen this development of AI models from when you were working on your PhD to today, and where do you think it might be leading us?
Yes, no, actually, I have to say that having the PhD was not from ECDC, was in this case from EPFL, helped me a lot in talking more or less the same language, because it's really impressive when you start discussing with AI experts that there's a lot of tacit and implicit knowledge in each single technical profession that we don't realize. So when we try to talk together, it's literally talking different languages. So that helped me a bit to get those initial steps, baby words on what AI could be done. And in terms of how the large language model developed, I have an interesting example in which we were preparing one of the publications that is actually available on how large language models could support extracting this public discourse, but also in comparison with the traditional AI methods, natural language processing, having experts, so trying to see in all these contexts. By the time we submit, we got the review, there were already so many new large language models that we had to ask the journal to add the results from 3 or 4 new families, let's say, because otherwise it would be already published, being an old article, just because there was, I think, 3-4 months. It was not that long time. So it shows the time that this is increasing, and it's getting more and more. So my wish is that as we move forward, we manage to get more understanding in public health, to see where AI can be implemented or in a safe environment, but also trying to test and have safest options or safest like sandboxes and so on to test the ideas, because sometimes you need to really go into innovation by testing those ideas. Again, starting with the problem, a clear task, but still until you don't work on that, it's not that easy to see. And then share also what we call failures, because what can be a failure for me can be an advantage for someone else that will not start from the same point that I started, but maybe later on. So I think we need to also, as I say, improve our understanding, and we don't need to all become AI experts, because that's not the way, but just to understand the minimum and share what we've managed to do, even if it doesn't work, because at least the next person that will try it will know that information, and that can speed up the process if we all collaborate.
Yeah, I really consider ECDC as being a public health agency that's really on the leading edge of applying AI into its day-to-day work. And so I think we've definitely got a lot that we can learn from you and your colleagues and the efforts that you've been making over the last few years. Yeah, you've discussed a little bit about the importance of working across multidisciplinary teams and with different experts from across your public health agencies. But like all cross or multidisciplinary working, there are definitely challenges in that and around how we communicate with each other. What are some of the challenges that you found with AI-related projects?
No, thanks. Indeed, I think that the main challenge that we found when it comes to communication among different disciplines is the implicit or the tacit knowledge that we have in all the professions. And at some point, we don't realize that this is specific to our own expertise. So experts on AI, experts on public health will have that implicit knowledge that the others will not have. So, for example, from the public health examples, we were developing a solution to extract epidemiological information from unstructured text. And we were working on the prompt. It was large language models in this case. And we were looking for how to classify or collect information on different type of cases. So we have all the options: suspected, probable, confirmed. And at some point, when evaluating in a short sample of text, the solutions, we were informing the AI experts saying, look, there's something wrong with this output because it didn't catch the confirmed cases. In that case, that was implicit knowledge, because what the text said is that the cases with lab result that was positive were that many. We will label that as confirmed, but the word confirmed was not there. And the tacit knowledge was that when there's a lab test being done which is positive, it can be labeled usually as confirmed. So after explaining that, then we decided how to approach. And also the fact that in epidemic intelligence, public health intelligence, we don't always have a gold standard. We don't know the unknown unknowns. So when we try to evaluate, we don't know what are the events that we are not seeing, because we don't know all of them. And that was sometimes a bit difficult to understand from the AI experts, because in other fields, you know what you need to get. So then you can evaluate, this is what I should get, this is what the AI solution gave me. So that's the evaluation or the accuracy. When it comes to the tacit knowledge from AI, there's a lot of information, of course, that is not available, but some that may be critical are that sometimes a small increase in accuracy can mean a huge increase in time and complexity. Meaning in threat detection, we need to know information really fast. If we have a model that is really complex, but will provide us the information 10 hours later, 20 hours later, is not of any use. So maybe we can get something which is less accurate, less adapted to the perfect standard that we may have in mind, but at least we have it now. So we have had this type of examples that we try to communicate to ensure that everyone would understand. We usually, when developing this project, especially talking about outsourced project, we have initial meetings just to understand what is ECDC, what we are doing, what is our objective, our solution, our constraints, to get the better or faster development. But of course, there are some situations that this tacit knowledge may come up. So what I suggest is try to ask and put the things into context. And it's always helping to have, like in my case and others with similar expertise, AI expert with a bit of knowledge of public health, or public health expert with a bit of knowledge of AI, because that helps in those translations in between the different languages.
If you think about maybe some generalized learning from you and your team that might help other public health institutions which might only just be getting started on their AI journey, what type of advice do you think would be helpful for groups, public health agencies, public health teams that are just starting to work with AI on a routine basis?
Yes, so for other teams, I think it's important, I would say, to focus on your challenge, to understand what is your need, your context, and constraints. And by constraints, I mean, what are the capacities? We cannot have a really complex solution that will require a team of 10 people if our team is not covering all those needs. It will never work. It can be pushed a bit to start, but then it will end up at some point. So I think by focusing on that, and in a way, it sounds like slowing it down, but if we stop a bit at the beginning, we will gain time later on. So we need to select the solutions that fit the problem instead of being constrained by the popular AI solutions that maybe is not for us. And if we start from the tool instead of the problem, that will lead to poor fitting, unnecessary complexity. So it would be really difficult to maintain it and keep it in our routines. So by having this problem-driven mindset, it ensures that all these AI tools are serving public health needs and not the other way around.
That's a fantastic place to wrap things up today. I think it's very encouraging. So we don't have to worry about always having the latest, newest, biggest models, but actually focusing on our objectives, our public health objectives, and understanding the workflow, and then getting into the AI from that perspective is a very practical and achievable perspective. Laura, thank you so much for taking the time to talk to us today. It's been fascinating. We'll put lots of links to all of the resources that you mentioned, and I look forward to seeing how ECDC continues to lead in this space.
Thank you so much for having me here.
Thanks so much for joining us for this episode. We hope you enjoyed it as much as we enjoyed making it. Be sure to subscribe and share this podcast with your friends and colleagues. We'll see you next time.
The Innovation Forum AI podcast is produced by Zoila Leiva Rioja and brought to you by the WHO Hub for Pandemic and Epidemic Intelligence. We'd love to hear your feedback and ideas. Reach us at pandemichub@who.int.